Welcome to today's webinar, Safe Prescribing Practices, Understanding the Relationship Between Prescription Drugs and Addiction. During today's presentation, attendees will be in a listen-only mode. To ensure that you can see all of the content for the event, please maximize your event window. To also maximize your slide view, click on the Scale button located in the upper right area of the window above the slides so that it shows as 100%. If during the program you would like to submit a question, please use the chat pod located in the lower left-hand corner of your screen. Type your question in the box at the bottom and click Send. If you have technical difficulties, you may contact the help desk at 877-297-2901. Now I'll turn it over to Jordan Esser. Please go ahead.
All right. Hi, everybody, and happy Friday. My name is Jordan Esser with the DuPage County Health Department, and I want to thank everybody for taking time out of your busy schedules to tune into this webinar on safe prescribing practices today. Before I hand it over to our speaker, I quickly want to share some resources and also thank the National Safety Council for their partnership and technical assistance on this webinar. Today's webinar is brought to you by the DuPage County Health Department and the DuPage County Prevention Leadership Team. The Prevention Leadership Team is a community-wide coalition working together to reduce substance use and increase mental health among DuPage County youth, specifically 18 years and younger. Our main youth prevention focuses are alcohol, marijuana, tobacco, and the prevention of drug use and misuse through safe prescribing and drug take-back promotion. You can learn more about the Prevention Leadership Team by visiting our website at dupageplt.org. The Health Department also has established the Hope DuPage Task Force, which spearheads DuPage County's opioid prevention efforts. Visit hopedupage.org for information on substance use prevention and education for both providers and patients. You can also find meeting agendas and minutes on the website. And their meetings are quarterly and open to the public. So if anybody is interested, feel free to join in on those. And then we also want to continue to encourage prescribers to utilize the CDC's resources and guidelines on safe prescribing and pain management. And you can visit cdc.gov to learn more there. So before we jump into the content of today's webinar, we have two quick polling questions which will help us establish some baseline data on participants today. So the first question should be up on your screen now. Do you use the PDMP routinely for every patient? Choose option 1 for yes or option 2 for no. About 10 more seconds. Okay. All right. And question 2. Should be up on your screen. Is PDMP data incorporated into your EMR in your practice? All right, just 10 more seconds. Great. Thanks, everybody. Okay, now I'm going to hand it over to our speaker, Dr. Al. Dr. Al provides chronic pain medicine services as part of the Interventional Pain Management Program at the University of Wisconsin School of Medicine and Public Health. He was appointed to serve on the Wisconsin Medical Examining Board to combat the state's opioid epidemic. Dr. Al also serves as Medical Director of the University of Wisconsin Pain Clinic and Pain Services Department. So Dr. Al, feel free to take it away.
All right, thanks so much for the introduction. And not sure how to get to my slides here. I don't see them on the screen. All right, now I see my slides. So thank you everyone for being here on a Friday, and we will have a very nice discussion today about the opioids addiction, use of the PDMP, and the opioid epidemic. Based on the first question here, I hope after our talk today that more of you will be checking the PDMP and using the valuable information to guide our patient management and planning for their health care. And I was introduced. My name is Ala Abdel Sayed, and I work at University of Wisconsin, and I go by Dr. Al. And I would like to thank the National Safety Council for helping us with this presentation. The National Safety Council eliminate prevention death at work, homes, communities, and work overall on promoting safety. The objectives of our talk today will be identify the history and scope of the opioid epidemic, describe pain and effective ways to treat it. And this is a very important objective that does help us to minimize the prescription of opioids if we can find effective ways to treat pain other than opioids. Identify the benefits and risks of opioid and non-opioid analgesics. Apply evidence-based guidelines and approaches. Describe the prescriber's role in combating the opioid epidemic. Educate patients on opiate use and risks and alternatives. Describe medications and when to refer to pain management and addiction treatment services. And I would like to start my talk with looking at this graph. Probably it's a popular graph, and probably we have seen it in more than one presentation before, but it's very indicative of how really bad is the problem. Started in 1999, and over time we've been having more opioid sales, more opioid treatment admissions, more death related to opioids. And it was until really the past few years when guidelines started to come out to try to control the problem. So the factor that we're contributing to the opioid epidemic by prescription medication is really the prescriber's lack of training on addiction, knowledge about the abuse liability of opioids, because there's been marketing for certain opioid medication. They are not addictive. So there have been a lot of some organization advocating and companies advocating for the use of opioids. Pain medication is reimbursed by insurance, but non-pharmaceutical therapies like PT, OT, yoga, and all those other modalities typically are not covered by insurance. So it's very common that you prescribe an opioid. It's very easily to be approved, but if you prescribe actually sometimes even alternatives and other medications, insurance may not approve them. And then having pain as a fifth vital sign, which made like every visit to a health system can bring a focus on pain by asking about the pain and the score, and then if the patient reports a score, then it has to be treated, and the treatment in many instances will be opioids. Then also patient lack of education regarding the risk of abuse and addiction. And it's very common that you'll see a patient has been on opioids for years, and they once you start talking to them about the risks of abuse, addiction, tolerance, they will immediately work with you on reducing their opioid use and use other alternatives. And then again, using patient surveys, which made it a problem because patient satisfaction scores played a role in the payment of physicians and health systems. And patients who didn't get their opioids sometimes scored the health system low or scored the providers low, which impacted kind of the reimbursement by insurance and personal salaries. So some people just prescribed opioids for the sake of having better satisfaction scores and having happier patients. And then the financial pressure, there is less time to spend with each patient. There is a move to productivity models. And it's easier just to write an opioid as sit with the patient, spend time, talk about PT, OT, infusion therapies, interventions, and have a big multidisciplinary plan that will include 5, 6, or 7 modalities to treat pain. For some people, it was quicker and easier just to prescribe the opioid rather than have a big comprehensive plan and chat with patient. So multiple factors, some of them are created by us, by policies, by decision makers that made the prescription of opioids very prevalent. And then the bad research. There are multiple articles that actually came. They were very weak articles that showed you can give opioids and that addiction is rare if actually patients are taking opioids for treating pain. And here's we citing one study, but there are a couple other more studies that came to the same conclusion, like it doesn't matter how much opioids you take, you don't develop addiction. And then the pharmaceutical marketing, which has been a big contributor to the problem, because companies came with products and they advocated that their products are not addictive like other opioids, like these are new opioids to be used. And to date, actually, still companies come now with opioids that say they are less addictive, and again, the next few years will show up the truth. The other thing is paying physicians, paying organizations, supporting activities to encourage people to prescribe their opioid. Here's another graph that shows you the drug overdose death by age group. And as you see, all over Canada's spectrum, the opioids cause the highest actually death as compared to other addictive medications. That's another very important graph here that shows once we started having the guidelines and policies in place and we started to pay more attention to opioids, you'll see that the natural and semi-synthetic opioids started to, they still increase in prescriptions, but actually not to the greater degree as synthetic opioids and the heroin. So some people, because the physicians stopped their opioids, they started going to street drugs, synthetic opioids, and to heroin. So now actually we're dealing with another problem of addiction, not the prescription opioids, but the heroin and street drugs, which is another challenge as we control our prescription medications. Then the progression from first opioid use to first overdose in Metro Cincinnati. So they did this study and they found that first use of opioid maybe at the age of 21 years old. And then people start maybe buying street opioids at the age of 25, and then IV drugs shortly after, and then the first overdose at the age of almost 27.6. And in many cases, addiction start with just as simple as starting an opioid after a surgery or just trying an opioid from a family member or from a friend for treating some sort of pain. And that's really become the hook, and then it goes downhill from there where the person will start just getting more and more into drugs, try to find them by other means, and then start to use them IV, and then overdose eventually will happen. And that's actually a very nice diagram that shows you how the problem started. So prior to the 90s, actually opioids were not widely marketed for use outside of cancer pain. So opioids were used constantly in cancer pain. But since 1996 to 2001, there have been some advertising and misleading campaigns. And then in 2001, pain management standards came out about using other modalities. And then in about more than a decade to follow, the CDC guidelines that came out as well as state policies. That's a very nice slide actually that can show the size of the problem of using opioids. So people who use alcohol are 2 times more likely to be addicted to heroin as compared to 3 times if people use marijuana, 15 times if they use cocaine. But if actually people use opioid painkillers, they are 40 times more likely to be more addicted to heroin. So it's very common to find that the heroin addict started actually by using opioids rather than cocaine, marijuana, or alcohol. Very interesting, and we see many in our practice because I do pain management for years now. I've seen many people who just went down heroin just by starting opioids actually through a prescription after a surgery or from a chronic pain clinic or by primary care. Then the CDC guidelines came, and that's kind of more to show you what they talked about, and we talked about this slide earlier. But the CDC guidelines came to have a stop sign to providers about just try to treat by other means. Don't start with opioids. And if you start with opioids, check the PDMP, have an opioid agreement, and understand the risk and benefits of using opioids. And we will talk more about this in the next slides. That's a nice article by the New England Journal that talk about the CDC guidelines. And I would like to refer here that CDC guidelines are not policies. So the policy is something we have to follow. Guidelines are just guiding the practice and the guiding provider for a better practice. So the CDC guidelines are not the Bible for pain management, and they intended for primary care providers. While I have to admit that some states interpret this differently and use the CDC guidelines as policies and has to be followed, but actually CDC guidelines are meant just to guide the practice, get providers' attention to a better practice of prescribing opioids, and understand more about the opioids and question their prescriptions before they do them. So we need to treat all those guidelines by care, but they are not a policy. Determining when to initiate or continue opioids for chronic pain. So you have to think very well before you start which therapy you will select and establish treatment goals and discuss the risks and benefits. And I would like to give an example here. If you start opioids in a patient, you have to first discuss with the patient the risks and benefits of the opioids. And you have to discuss with the patient why we're doing the opioids and which opioids we will be prescribing, and then what are the goals of the treatment. It will be very common to see prescribing opioids, for example, for the next 6 months until the patient can get into physical therapy and start working out, increase their muscle core, and adopt maybe a better healthy lifestyle, work out to lose weight. So this way we're giving them the opioids for a purpose. And at the end of the 6 months, there will be a discussion that at the end of 6 months we will wean down the opioids down to 0 and just continue with other modes of treating pain. So opioids can be helpful, and that's what I would like to focus into my presentation. We don't want people to think being on opioids is a stigma. Opioids are needed, but they need to be for a purpose and for a certain duration of time at certain dose to achieve a certain goal, and then you can stop them. So that's a very good use of opioids. The HHS draft report of pain management best practice. The number one, current inconsistencies and fragmentation of pain care limit best practices and patient outcomes. A coherent policy for pain management within health systems is needed. And that's again a very important point because actually if you look at the CDC guidelines, they are not similar to the state guidelines in many states, and then institutes perform their own policies or guidelines, and then departments inside the institutes may adopt different guidelines. It's very important just to align up all those policies and guidelines together to have one unified approach. Then approaches to pain management. It's very important to encourage coordinated and collaborative care that allows for best practice and improve patient outcomes whenever possible. So while opioids treat pain, they are just one modality. There are too many other modalities to incorporate into pain management, like as we talked, physical therapy, occupational therapy, pain psychology. I mean, I can name more and more, and we will talk about this in the next few slides. But opioids is just one part of the pain management multidisciplinary approach for patients. Then medications. Clinical policies tend to treat the larger population of patients with multiple different conditions causing chronic pain with simple medication rules. Guidelines for medication use for a specific population of patients with chronic pain need to be developed for each specialty group and setting. And that's another very important slide here. We talk about opioids for everybody. But there are patients, like there is a difference between an athlete coming with knee pain that probably I can treat with physical therapy, and between a patient who have systemic lupus erythematosus, systemic disease, who maybe need opioids and I can't treat it by many other means. So the fact that we make one policy or guidelines for using opioids for pain is not appropriate. We need to focus very well on individualizing the treatment to different patients, different situations, different age, patients with other comorbidities, systemic diseases or musculoskeletal diseases, and find the appropriate niche for opioids for the appropriate patients. Then develop condition-specific treatment algorithm that guide physicians to have a more individualized approach for common pain syndromes and conditions. And simply in my institute here, we started to have treatment programs for sickle cell anemia, for patients with fibromyalgia, patients with Ehlers-Danlos syndrome, and many other disease conditions. It's extremely important in every institute that you develop and organize a protocol and approach to how will you treat every single condition. For many reasons. Number one, you create a good evidence practice that can be used for treating patients. It can include opioids or may not include opioids, but you will develop a nice evidence-based protocol to treat a certain disease condition. And particularly, I'll take sickle cell anemia and sickle cell crisis because that's a very challenging condition. Those patients will be constantly in pain. They will have their flares and crises. They will show up to the ER and be admitted to the hospital. And they create a confusion to everybody. And what happens is that those patients will be treated differently depending on where they show up. ER different from inpatient, different from if they come to their primary or pain clinic. So it's very important to have one algorithm, one approach to treat those patients that will cover all those situations, whether they show up to ER, inpatient, outpatient, primary care, pain clinic, or hematology. Having one algorithm is extremely important. Second most important is when you have this algorithm, this means all providers in the system will use the same algorithm. So this patient will be treated the same way wherever they show up. So the patient, you will not have to do like things differently and maybe get out of an algorithm to do your own approach for treating sickle cell anemia. That might or may not be an evidence-based approach. Also, those algorithms are important because when the patient goes in the inpatient setting, for example, they get treated. And then a plan will be formed to how to handle the management in the outpatient setting. So this way the algorithm will allow for continuity of care, will decrease the unnecessary overuse of opioids or other prescriptions, and it will be basically a one line of management by different providers at different facilities and phases of care, but treating the patient with the same algorithm. So I encourage you all, develop this in your institutes and you'll see a magnificent difference in patient care. Then I would like to define opioids because there are too many types of opioids and there are many receptors opioid will work on, and still actually companies work on developing more and more opioids. So there are, for example, the natural opioids like morphine. There are semi-synthetic opioids like hydromorphone. And there are the synthetic ones which we see really more problems with nowadays, like the methadone, fentanyls, because people synthesize them sometimes in a non-regulated fashion, which cause danger of using those opioids. And this is actually the state of U.S. health, years lived with disability. And this is very important to show you that pain actually is one of the major contributors to disability in the U.S. There are many other reasons for disability, but low back pain and musculoskeletal disease overall represent a big portion of our people who live in disability and apply for disability and show up to our healthcare systems. That's why it's very important to develop those algorithms and have a very tight management plans, hopefully to catch the pain early in its course and try our best to prevent the disability. So when it comes to opioids, so you have to think when you select an opioid, are we selecting immediate release or extended release and why and which ones? And whether we're going to use only extended or immediate release or both of them, then you have to consider very well the dosage. Again, using the CDC as a guidelines about how much we should prescribe. And then you have to think about the duration of treatment and then the follow-up and when you will be discontinuing the prescriptions. And as we mentioned in our example, we might start opioids for a patient to just get into physical therapy, lose weight, and then we will discontinue those opioids. This plan has to be discussed with the patient. We may need to start with an extended release medication for more prolonged coverage, and then use with it an immediate release medication for breakthrough pain. Then always start low and go slow. No need to start with high doses. Start with low doses and titrate to effect. Keeping in mind the guidelines, and the guidelines, while they recommend less than 90 milliequivalent of morphine, but they don't prevent you from going above the 90 if you think it's appropriate to go above the 90 milliequivalent of morphine. And then the duration. It has to be very well discussed with the patient, so no surprises or arguments at the end of the treatment duration. And then during this duration of prescription of opioids, please make sure you check the PDMP regularly to make sure the patient is consistent and is not getting opioids from anywhere else or not showing any concerning behavior. Finding those concerning behaviors on the PDMP have led me and many others to stop opioids for certain patients, which reduced the risk of addiction and maybe addiction for people who live with them or surround them. And then make sure the follow-up will be monthly or every 2 months or every 3 months, how frequent you'll be checking the PDMP. Please pay attention to your state policy as well about how frequent you should check the PDMP. And if you have any concern, do a urine drug screen. I recommend doing a urine drug screen before you start using opioids to make sure there are no illegal substance or other street drugs in urine, because that in itself is a risk that you don't want to take. And then do it randomly as you find appropriate during the treatment duration. So this graph is very important because it shows you that many people actually prescribe opioids for longer than CDC guidelines. I'll give an example to this. A patient will have a surgery and maybe need opioids for a week. The patient might just keep getting refills on opioids for like few months following the surgery unnecessarily, maybe just need it for a week. So actually a lot of patients, big portion of patients get actually opioids beyond what they need, which can create the problem again of addiction tolerance and the inappropriate use of opioids. It's very important to use all those assessment tools before starting opioids and as actually the patient is on opioids. So there are many actual risk evaluation questionnaires available out there that I really highly recommend using them to evaluate the risk factors first. Those risk assessment tools will give you a score at the end. If the score is high based on the questionnaire you're using, that might be a high-risk patient for use of opioids. Maybe just avoid opioids for this patient. Again, do a urine drug screen. Check the PDMP even before you start opioids. This patient may have concerns and flags that will make you concerned about prescribing opioids. And so I would recommend really doing those 3 things before starting opioids. Evaluate the risk, check the PDMP, and do a urine drug testing. Make sure you're dealing with a patient who will benefit from the medication. And then when you try to co-prescribe benzodiazepines, again, I highly recommend against this, but again, some patients need it. So just evaluate the risk very well. Understand that both of them might be slightly dangerous to the patient, so maybe give lower doses and at different times of the day, and again discuss an end duration for this co-prescribing. Chronic co-prescribing of both is definitely not recommended. And these are some of the increased risk of using opioids. Apnea can happen, so be sure if you have a patient with obstructive sleep apnea, obesity, be on CPAP at night, just reconsider prescribing opioids because that might cause respiratory depression and can endanger the patient's life. Pregnant women, again, put them at high risk. Renal and hepatic insufficiency can be a problem because if you give certain opioids for those patients, the metabolites will accumulate and cause side effects. And then ensure treatment of depression and anxiety and any psychiatric disorder is optimized before you start opioids. Because again, let me say you see a patient with suicidal attempts before. Will you give this patient opioids? Will you give them like a tool to commit suicide? And trust me, it's not uncommon that you will find a patient who tried to commit suicide before by other tool and then you prescribe opioids. and then they will use the full amount of opioids, overdose, and die. So please be very mindful before you start opioids to all those factors and even more. It can be as simple as a patient I had one day who fit everything. I can very comfortably give her opioids. But then she told me, as we chat, that her son is a heroin addict who tried to harm her and steal her drugs. So that in itself is an issue that got me concerned about prescribing opioid for this patient. You either have to come up with a plan that to make sure those opioids are locked in a safe, far from any reach, or maybe discuss with the patient maybe having opioids will endanger her life and her social situation. Just have a discussion with the patient and pay attention to everything the patient will tell you to be able to estimate the risk. And again here, these are all risk factors for the prescription of opioids that we have to think about. And this is a very interesting figure that shows you that only 32% screen for family history of addiction. And I just mentioned the family history of addiction is incredibly important because that just can simply a flag that you shouldn't be prescribing opioids. So here are the percentages of providers who check on history of opioid use, 84%, history of illegal drug use, 77%. So 1/3 of providers will not even ask the patient, are you using illegal substance now or before I give you opioids. Screen for history of illegal / prescription drug abuse, 77%. Check with a state drug monitor, the PDMP, 57% only will check. Screen for family history of illegal and prescription drug abuse, 32%. Screen for smoking, 24%. Check for history of incarceration, 14%. 5% will not check any of this before they prescribe opioids. I think this slide makes a very clear point that we under-evaluate and estimate and evaluate the patients before starting opioid prescription. And I think that's one of the main contributors why we had all those problems of opioids. Because if we think about if we give opioids to the appropriate patients in appropriate doses and we monitored what we do appropriately, we wouldn't have the problem we have today. These are all like names of risk assessment tools. Use the shortest, simplest one. They are all around, available, and for free. Can be used in any practice. Rule of PDMP, the PDMP. So I saw in the first question that some will not check the PDMP, and I understand it can be actually challenging to check the PDMP, particularly if it's not incorporated in your electronic medical records. It can be a hassle trying to remember your password to log in. Takes time to check every patient you prescribe opioids for, but I highly recommend their use. Because they just can show you that where this patient goes for their opioids. Sometimes you see the patient going to 6 providers using 6 pharmacies. This is a flag that this patient shouldn't be on opioids. This patient is doing something wrong. And also the importance of the PDMP, it does help you to check surrounding states. I personally live in Madison, and we have our patients go to Iowa and Illinois, and our PDMP allow me to check other states. And we will find patients who go to other states to just bring opioids as well. So another flag, why would patient travel in 3 states to get opioids? And then by numbers, which I'll show you now in multiple states, the use of the PDMP actually allowed for reduction of opioid prescriptions. And I would like to give this example of one of my colleagues who inherited a heavy opioid practice. When I say heavy, a provider retired and his patient was on about, on average, 1,000 milli equivalent of morphine a day. And then the provider who inherited the practice just called me one day told me, what shall I do? Those are very scary high doses. And I told him first thing, check PDMP and do urine drug screens for your patients. And immediately he could actually find maybe 30% of those patients are misusing the drugs, going to other providers, or had concerning urine drug screens, and he simply cut those patients gradually down to 0 opioids. You'll be surprised. So please use the PDMP and make sure you try to develop a system. I know if it's time consuming, before actually it became integrated in our electronic medical records, our nurses used to check it the day before. So one of the nurses or MAs will check them the day before, so we have the reports in the morning. So we have it already before we decide on prescribing opioids. So please use the PDMP this will allow you very well to continue to practice safe prescriptions. That's what's happening in Florida. If you look, Florida, one of the states that has a major problem with using opioids. But after they started enforcing checking the drug monitoring system for the state, you can see how well they did by reducing their prescriptions. I would like to use also my state as an example. In Wisconsin, we have a fantastic PDMP. It's integrated into all electronic medical records. And the state here mandated that we check it with every opioid prescription. And you can see there is also reduction in the opioids prescribed. So it does help to identify the appropriate patients for opioid prescriptions. I'd like now to spend some time talking about naloxone. Another important drug that we started hearing about in the past few years was all the opioid overdose, heroin overdose. So it's been a valuable drug when we actually had high opioid prescription before guidelines, and now remains a very valuable tool to patients who use opioids, and actually even if they use heroin or other things, they will have it in their home to save a life at one point. And there are multiple preparations for its use. Here we have the vial, but there are the nasal sprays and other forms that can be used easily by patients. So naloxone overall is just an antagonist. It does block the effect of opioids. It has very few contraindications or side effects that honestly in my practice I have never seen any. Physicians can provide a prescription for naloxone for patients at risk of overdose. And actually there are pharmacies and programs that allow patients to walk in, no question, purchase naloxone at an affordable price. And the CDC actually guidelines recommend providing naloxone for patients with history of overdosing or substance use disorder, patient opioid dose of more than 50 milliequivalent of morphine a day, and patients with concurrent benzodiazepine use. So again, go back to your practice, make sure you're prescribing naloxone to those patients. It will protect them from overdosing, whether intentionally or unintentionally, and whether for the patient or any family members or anybody who might get hold of the drugs. And in Illinois, there is a prescription monitoring program that, again, I encourage everybody to use to provide appropriate prescription of opioids. And if prescriptions from multiple sources, high dosage or dangerous combinations, do not dismiss patient from care. And this is one of the major problems that happen in when a provider check the PDMP urine drug screen and find the patient to be inconsistent or a high risk or using high doses, going to multiple providers. I'm aware of some clinics who will dismiss the patients, but that's not the right approach. The right approach is to put the patient with addiction if possible, put them in counseling, wean them down gradually off their opioids, and introduce many other modalities for their treatment other than opioids. So don't dismiss the patient, just work with the patient using other modalities. Then the substance use disorder. So this is one term. There are many terms we use in our, when we deal with opioids, substance use disorders, tolerance, or misuse. There are multiple names we give to the use of opioids and other substances. But substance use disorder occur when the recurrent use of alcohol or a drug causes clinically and functionally significant impairment, such as health problems, disability, and the failure to meet major responsibilities at work, school, or home. According to the DSM-5, a diagnosis of substance use disorder is based on evidence of impaired control, social impairment, risky use, and pharmacological criteria. And I wanted to get this slide here with those definitions because sometimes we overuse the term substance use disorder in our notes and documentations. It may not be substance use disorder. It might be tolerance. It might be, again, misuse or any other thing. So make sure if you want to label the patient of substance use disorder, which will guide the management of this use disorder, just please make sure they fit those diagnoses and criteria. And again, at the end of the day, follow what your gut will tell you and make sure you work with the patient on addressing the problem. Then if you find that the patient has a substance use disorder or addiction, These are the four usually modalities used for treating pain. You can do detox and abstinence. You can do detox monthly shots of naltrexone. You can do medically assisted treatment with buprenorphine or methadone. And actually, the medical assisted treatment has so far proven to have the best outcomes in literature. And when you come to treat substance use disorder or addiction, we all know there are limited resources, there are limited programs, and usually patients in addiction will not have adequate insurance coverage, so we have to utilize state-funded programs and work with those patients on addressing the problem. That's why the medication-assisted treatment can be done on an outpatient setting. It's more cost-effective and less time-consuming for the patient and the health system. And that's why I think that you get better outcomes with it. And again, here's the best outcome. Counseling, reduce mortality by twofold. So these are all increase the mortality by twofold if you don't do it with medical assisted treatment, but actually it improves outcome if you do counseling with medically assisted treatment. And looking at this slide is not only about focusing on one thing, but treating addiction is, again, it's a multidisciplinary process. It's not like one thing you will give them methadone and they will recover their addiction. You have to work with them on the social level to get away from friends who use those drugs or family members who use those drugs. Give them the medications, get them busy with physical therapy and addressing their problems, get them into education, counseling. So it is a multidisciplinary approach. It's not a one thing you will use to treat addiction or substance use disorder. And again, opioid analgesics are used for all those indications: abdominal pain, headaches, elderly who fall a lot, people who have eye pain, are used for all kinds of those indications. So general prescription guidelines. First of all, start with non-opioid therapies. You don't have at all to start with opioids. Just start with anything else, anti-seizure medications, neuropathic agents, infusion therapy, maybe interventions if you find appropriate, pain psychology, counseling, all of this before you start, over-the-counter medications. And then do not use opioid routinely for chronic pain. It's a problem because once you started in chronic pain, again, you have to, as we mentioned, address the risk, harm, discuss with the patient treatment goals and durations. And as we talked about, start low and go slow. And monitor very well as you start your opioids. Monitor urine drug screens, PDMP, and have an opioid agreement to make sure patient is not obtaining opioids from multiple sources. And these are 8 opioid safety principles. Never take an opioid pain medication that's not prescribed to you. And those principles actually have to be conducted very well to the patient. Never adjust your own dose. So patient can't come one day to tell you, I found myself in more pain, I'm taking 2 pills rather than 1. That's not allowed. Never mix with alcohol. Using sleep aids and an anxiety medication with opioids is dangerous, and this has to be very well conducted to the patient. Some people will take those medications, sleep, and never wake up again. Always disclose all of your medications to providers. Keep track of when you take medications. Keep medications in a safe place. Extremely important. Majority of people actually bring those opioids from family and friends as a major source. So it has to be logged in a very safe place. And very important to dispose and use the medication. Very common to find people who get pills after surgery, keep them in their cabinet, and several months to follow or years to follow, somebody will get hold of those medication and inappropriately use them. And these are all medication alternatives. If you look at this, we can give NSAIDs, we can give acetaminophen, we can give anticonvulsants, tricyclics, antidepressants, muscle relaxants, topicals, and more and more. These are all modalities for treating pain. And by the way, if you look literature, these are all modalities that have much better evidence in treating chronic pain than opioids. I'll be discussing in the next few slides briefly about those modalities. And I would like first to refer to what's called number needed to treat, because we will use it in the next few slides. Basically, it is the number of people who must be treated by a specific intervention for one person to receive a certain effect. So the lower the number, the more the effectiveness. So keep this in mind. The lower the number, the more the effectiveness, as we discuss the next few slides. So that's another actually opioid efficacy, when actually they screened providers about which ones you think will be a safer medication or more effective for treating pain. So 74% believe that opioids to be most effective way to treat pain. So this is what we actually had here. But actually the efficacy is 34%, is not that high. And if you look at here acetaminophen and ibuprofen in the first two columns, actually these are 62% effective, the highest efficacy in treating pain. But only 1% of people who got the survey thought that this is actually real. Ibuprofen only 400 milligrams, 40% efficacy in treating pain, but only 4% knew this. And as you go to opioids here, you find that there's discrepancy between what people believe and what actually the efficacy is. So more people believe that they are effective than they are. And here's again a graph that shows you the efficacy, the actual efficacy in treating acute pain, and that's acute pain. So like if you show up to the ED or following an injury or a trauma or a surgery, as you find here, morphine comes to be number 5 efficacy. Oxycodone, very low efficacy, but all the other alternatives, ibuprofen, acetaminophen, actually proven to be the most effective. And again, as we mentioned, it can be starting a pill after a surgery is the road to addiction. So if we can use the other modalities as much as we can, we save the life of many people. So we'll talk about the tricyclic antidepressants. And again, I want to focus is that there is nothing with no side effects. So we have to understand the risks. But again, if you look at the risk, probably much more less than opioids. So here, they can be used to prevent and treat chronic pain, but their risks are dry mouth, sweating, dizziness, blurry vision, which basically the anticholinergic side effects. And they can help with the sleep, which is another important thing for patient pain that may help them to sleep, so they don't need sleep medication. Then we'll talk about the SNRIs, or selective norepinephrine reuptake inhibitors. And again, their number needed to treat is 3. And again, they have some risks here: nausea, somnolence, dry mouth, constipation, and other side effects. We have to, again, to discuss all those risks with patients, because a patient, if can't tolerate those side effects, probably we need to shift to another class of medications. Then we come to the anti-seizure medications, which again can be used for treating pain. And as you see, the risk factors are much less than the 2 previous groups we used. And these are actually the ones we will use more frequent in our practice. Then the topical analgesics. These are the nicest and probably one of the most safe modalities, and can be sufficient for some patients. And the only thing we see is skin irritation with the topical medication, but otherwise pretty safe. This is a slide to recap. Actually, this slide and the next one, I want you just to see here that these are all modalities we can use for treating pain. So opioids and medication, just one thing. But think about physical therapy, occupational therapy, pain psychology, mind-body, pet therapy, acupuncture, massage, music therapy. These are all modalities we didn't even start talking about non-opioid medications. Keep them in mind and start with those modalities. And again, these are all the terms and the problems that can happen from the use of opioids. No matter what we name it, it can be a problem. So it can be diversion, it can be, again, it can be overdosing. Just always think about no matter what the term is, we have a problem. And again, this slide shows you other things you can use: cold, heat, diet. Diet is a very important thing, actually. I have treated patients only by diet control. If people make dramatic changes in their diet, using more antioxidants and anti-inflammatory foods in their diet, they can just totally recover their pain. And then the interventional therapies, which is an option we give actually before or after we start opioids. You have to discuss with the patient risk and benefit and what intervention we will do, what medication we will use. It's a big, broad thing about using steroid injections, radiofrequency ablation, spinal cord stimulators. They all have their place in the management of pain, probably after failure of all other modalities. And that's, again, summary of some of the modalities we use for treating pain, and they should be always considered whenever the other modalities fail. The inherited patient represent a big problem, and these are patients that you need to chat with them about. So you need to educate the patient first, and then involve the other team members in the management to make sure you can actually wean down safely of their opioids. And we will talk in the next few slides about the inherited patient. So confirm medication and dosage, and direct correspondence with referring treating clinician. Check the prescription, again, the PDMP, to make sure these are actually appropriately using their medications. And do a urine drug screen, as we mentioned before, because checking the PDMP and doing a urine drug screen can maybe simply show you that this patient is not appropriately using the medication, and then you have to be weaned down. Then again, discuss the risks and benefits. Reassure the patient, treat pain with other modalities, start lowering gradually the dosage, and ideally, taper off if you can stop. If you can't stop, just maintain them on appropriate monitored doses. And most importantly, try to use other modalities to make them sure they're comfortable as you wean down their opioids. And common patient concerns always to keep in mind: they fear pain, they fear withdrawal, they fear judgment by family and friends. They worry about actually that nobody believes you have pain. So you have to work with the patient and assure them you do believe their pain, and you're going to do your best addressing their pain concerns. And how do you taper? Actually, there are too many ways people taper medications. So the longer you have been on opioids, the slower the process should be. Patients taking opioids as needed on a daily basis can often have their medication discontinued without tapering. Goal may be to get to safer doses, not discontinuation. And then make sure you just address the patient and anxiety, duration of therapy, and comorbidities as you wean. And keep in mind that no matter how you're going to do it nicely, you might have a risk of withdrawal, and be ready to treat withdrawal if it happens. And there is no, again, agreement about how we should wean the patient. But again, I personally would like to do 10% decrease weekly. It can be every few days. It can be every 2 weeks, depending on how the patient can tolerate it. And again, some people can wean down at 20% rate. Some people can wean down on 5% rate. So start with 10% and then adjust your taper as you go. And sometimes you have to just pause and, for example, if the patient really can't take it, maybe just pause the taper process for 2 or 3 weeks and then restart it again. So make sure you start just somewhere. I think the 10% is a good way to start, and then adjust from there the duration and frequency and dose. Again, you can rapid wean sometimes. You can consider formal detox. Some patients will be on very high doses and very resistant to the weaning process and may develop withdrawals. So consider formal detox inpatient or an outpatient program. And at all cases, you have to provide psychological support to counseling and non-opioid pain management. And then identify or treat symptoms, like a patient will have an anxiety, depression, opioid use disorder, so please address those as you wean down, address withdrawal, address sleep impairment that may happen, and make sure you don't add a controlled substance during the weaning process like benzosoma or other sedative hypnotics. So if you're trying to wean the patient from an addictive substance, don't add another addictive substance to help you achieve the goal. And then these are all resources about how to guide the weaning process. Again, remember always the number 10% might be a good way to start. And these are the challenges you will have. CDC guidelines becoming a legal standard, unfortunately, in certain situations, and that was never the intention. Keep in mind that doctors are scared of regulations and the incentive of patient satisfaction scored, providing timely access to care, coordination of efforts, and changing the public perception. These are all the challenges that we all need to work on together, hand in hand, to make sure we change kind of the perception, and to make sure the CDC guidelines are treated as guidelines, not as policies, and that nobody should be penalized if they don't follow the guidelines. And again, make sure we work with patient and patient satisfaction scores, work with our systems to make sure as we provide the appropriate care for our patient, nobody will be penalized for doing this. Warn Me label, it's another good resource by the National Safety Council that I encourage you all actually to read about. Here is some about it. And these are all very good resources actually by the National Safety Council that again encourage you to go to the website and utilize those resources as you try to guide your management for pain and appropriate opioid prescribing. Again, thank you so much for being here today, and I'll be happy to take any questions. And maybe the moderator want to take the control back to moderate the questions.
Okay, thank you. I just want to remind our attendees, if you'd like to submit a question, please use the chat pod located in the lower left-hand corner of your screen. Type your question in the box at the bottom and click send. We do have a question that came in already, so I'll go ahead with that. There's two parts. The first part of the question is, what's medical food?
So when I mentioned about this, I mentioned about healthy diet. So healthy diet basically indicates, giving up all the bad diet behaviors and use more of nutritious the dietary components that have more antioxidants and anti-inflammatory, like using more, the healthy vegetables, healthy fruits, as opposed to red meats and other things. And actually there is a question about resources here. I myself authored the book, and it has a very nice chapter on nutrition and a diet for patients in chronic pain and how they should eat and what is the beneficial foods for them. But overall, going for a healthy, the regular healthy nutrition by using the appropriate vegetable fruits, avoiding, the carb and sugars, typically that does help with pain.
Okay, and the second part of the question is, do you have any suggested resources for dietary recommendations for pain management?
Yes, I mentioned about my book, Chronic Pain, The Patient and Family Journey. That's how it's called. And probably if you read about in regular literature, probably you'll find articles that will take probably, I'm not aware of one sources that will get you all, but you might find things about different nutritions for different diseases, for example, like importance of vitamin C in complex regional syndrome and so forth.
Okay, our next question asks if you use gabapentin and Lyrica before TCAs and SNRIs.
And the answer is yes. I use gabapentin as a first option because typically insurance companies will actually not approve Lyrica unless you use gabapentin and fail. And because gabapentin is a cheap and very effective drug, and it has less side effects as compared to the SNRIs and the TCAs.
Okay, our next question is, in your opinion, what is the relationship of the opioid overdose epidemic as it compares to the emerging stimulant overdose increases in the U.S.? Do we need to look at substance use or disorders more holistically because of this?
And a very, very good observation, actually. And you're right. I think actually people started using more stimulants as they wind down opioids. So nationally, we're seeing an increase in the use of stimulants. Which now actually I myself writing an article about it to get people attention to that we're not trying to treat a problem by a problem, but definitely it needs a national attention. In some states the increase in stimulants were not significant, but it was significant in other states, and that's definitely an issue that needs attention, that also stimulants should not be prescribed in high doses.
Okay, our next question. What is the best way to identify appropriate referrals to treatment in your area in case patients do need help addressing a substance use disorder? What's the best way to link them to this care?
So I work at UW Health System, and we have an addiction department, and it took me actually a long time to be able to hire an addiction counselor. So building up this foundation will take time, but I encourage everybody in their system to start advocating for this practice. So again, refer to addiction programs if they are available in your institute. If not available in your institute, then please, I'm sure you have a close by health system that will have addiction services that can treat your patients. And then communication with the Department of Health actually in each state might be helpful to provide you with resources for unable patients.
Okay, our next question. What is the role, if there is one, for medical marijuana in the treatment of chronic pain and or as an alternative to opioids?
Another good question. So while some are advocating for use of medical marijuana to treat opioids or reduce the opioid prescription, I personally recommend against this practice. Medical marijuana honestly might have something there and it might be beneficial, but there is no single nice article that actually provide a good evidence about their efficacy, particularly in treatment of chronic pain. And this reminds me with the few decades ago when some weak literature came advocating for opioids, and now we have the opioid epidemic. I personally think we're going to get into medical marijuana epidemic maybe in the next years because there is no good literature to support them. And also the practice of medical marijuana is not regulated. Basically people just prescribe anything. And it has THC, it's free of THC, you have the hemp products and you have the non-HC products, and simply everyone having a thought about medical marijuana can go plant marijuana and just squeeze it and sell it. So unfortunately, it needs to be more regulated by the FDA, and until we have FDA approved products with good, strong evidence behind, I don't think medical marijuana is the appropriate product for in chronic pain right now.
Okay, and here's, I think, a related question that you may have answered. Do you have experience using cannabis as an alternative to opioids? I've seen research that does not support it.
And that's true. There is like articles that support them, and there are articles that doesn't support them. But overall, again, I don't see one strong evidence to be using cannabis in treatment of chronic pain at this point.
Okay, our next question. Our attendee would like to thank you for a great presentation and says that you mentioned to create algorithms based on pain conditions to achieve standardization across various areas of care. With so many pain conditions / diagnoses, what is the best way to go about this?
That's another great question. And the way we did this is we approached kind of champions in all departments. I'll take an example of sickle cell disease, where we contacted people in hematology, pain management, family medicine, pharmacy, acute pain, and every single person really we could get hold of. So we asked the department chairs to send us a champion. And now we formed a task force that will meet monthly or on monthly basis to develop this algorithm. And this way, so I mean, one person hard to do this work. You need multiple people with multiple expertise to look into literature and pull their most recent evidence and have an algorithm that agreed on by the group. After this algorithm is approved on by the group, we pass it into a bigger group. So for example, it will go to the multiple departments and we'll pull more people to review the draft before it goes to be implemented. And then we will take this algorithm and put it into actually electronic medical records, so it's approachable by anybody. As you're seeing a patient, you can just simply go and simply just kind of review the algorithm as you treat your patients. So it takes time. It might take 1 or 2 years to develop one algorithm, but the main thing is to have a task force group represented by multiple specialties.
All right, moving on to our next question. What is the responsibility of the pharmaceutical industry in tracking their product from production to consumption?
So that's a very good point. They're actually very responsible. And right now, actually, there is a big sue against the company that makes Suboxone because it's available public. So that's why we can speak about it. Because they advocated that the antagonist, their buprenorphine, is not addictive. And then they found to be addictive, and then there is a big legal allegation right now. So unfortunately, some companies and pharmaceutical, like industrial entities, advocated for use of drugs. That years to follow, we found that they are not what they are advocated for. And I would like also to be fair, that didn't happen only for opioids. It happened for many other products over the history. That's why many products to treat, hormone replacement therapy and other products got withdrawn from the market after years of use. Because they found to carry more risk than benefit as advocated by the companies. So sometimes Sometimes they are actually do it for a good purpose. That's what they know. And sometimes you do just for marketing and money. But many companies right now are developing actually post-marketing studies and actually databases to capture any risk factors or problem that may happen to their products early after marketing. So they are definitely responsible. And I encourage you, if you have a concern about the product, I think it's our responsibility as well to communicate with the company to get their attention that their product might have a problem and they need to address.
All right, our next question is, when should you co-prescribe naloxone if opioids are needed?
Again, I go very conservative, so if the patient is going for more than 50 milliequivalent of morphine, I'll give them a prescription of naloxone. But again, it depends on where you practice. But I think above 50, it might be more conservative than other people practicing, but it's not a bad practice.
Okay, that appears to be our last question right now, so I'll turn it back over to Jordan at this time.
All right, thank you. Again, we just want to thank everybody for their time, and thank you, Dr. Ale, for a great presentation. Just a couple last housekeeping things. We will be following up with email to participants next week, probably around Tuesday. That email will contain some resources and also a link to this webinar, a recorded version of the webinar. So if you want to rewatch or send it around to colleagues, please feel free to do so. We will also be following up with CMEs. If you have any questions about CMEs, you can contact me at jordan.esser@dupagehealth.org. But we'll put some information in our follow-up email that's going out next week as well. And with that, I'm going to turn it back to the moderator to walk us through our evaluation.
Hey, thank you. So thank you for joining us for this webinar today. We appreciate your attention and participation in today's event. To assist us in future webinars, please fill out the short survey currently on your screen. You may now disconnect.